Welcome to the NJ Spotlight Roundtable Series. In this program, the impact of Medicaid expansion on New Jersey's healthcare system. This program was recorded in Trenton, New Jersey on March 7th, 2013. This program is brought to you by Amerigroup Real Solutions in Healthcare, the Hospital Alliance of New Jersey, and the Nicholson Foundation. Panelists on the program today are Dr. Poonam Aleg, former commissioner of the New Jersey Department of Health and Senior Services and a board member of the Common Sense Institute of New Jersey. Raymond Castro, senior policy analyst from New Jersey Policy Perspective. Susanna Yanni, president and CEO of the Hospital Alliance of New Jersey Incorporated. John Kern, CEO of Amerigroup New Jersey Incorporated. And State Senator Joseph Vitale, Vice Chair of the Health, Human Services, and Senior Citizens Committee. Moderating the program is Andrew Kitchenman, healthcare reporter from NJ Spotlight. In this program, Chapter 3, Audience Questions for the Panel. Moderating the questions is Andrew Kitchenman, healthcare writer for NJ Spotlight.
Here's a question from an audience member. The person's child is dual eligible with a serious and persistent mental illness. They point out that the increased reimbursements of having a Medicaid be 100% of Medicare is for primary care providers, but they ask, what about specialists and psychiatrists? Right now, there aren't any private psychiatrists in Mercer County that accept Medicaid. So how is this serious deficiency going to be addressed? Does anybody have any thoughts on that?
So I think the question's a very fair one and a good one, and frankly a tough one for the state. Look, there are certain provider types that everybody struggles to get, both in the commercial world, in the Medicaid world. Behavioral health is something that is carved out from the managed care companies, as the commissioner pointed out. So that lack of integration, frankly, I find troubling. There are plenty of our patients who we know, in addition to the acute care needs that are before us, have behavioral health needs, and the lack of integration is very troubling. What I would hope would happen with the increased rate of payment on the PCP side is it would lead to some more doctors considering it as a possibility. As I mentioned earlier, all too often in conversations I have with doctors, and as soon as I say Medicaid, they're not even willing to hear what payment rate you're willing to make. And sometimes we are willing and able to make payment rates that work if we can get somebody to listen. So hopefully it changes the conversation a little bit, but it is going to be a problem going forward.
One of the things in the comprehensive Medicaid waiver is to look for an administrative structure that will help integrate behavioral health needs to the medical needs of patients. Right now, it's all fragmented, but to have that one arm that's going to interplay and coordinate care with the medical issues of patients is going to be critical. The risk is still going to be with the state, so the state's going to pay for those services. However, the administration and the coordination. So I'm hoping that that's not going to be the answer, but that is sort of a bridge to what we need to do. The other piece around behavioral health is we're going to have to look for non-traditional providers, even in behavioral health. I know that some of the most successful behavioral health providers are your social workers or your nurses who had that special training. So we're going to have to start tapping into, yes, right? Absolutely. So we're going to have to start tapping into it so that it truly becomes a multidisciplinary team approach. It's not just the psychiatrist who's rendering the care, but it is a team approach with different disciplines and your medical provider doing it all together.
I think that, as I mentioned before, the expansion gives us the opportunity to sort of experiment with some of these services. So why don't we do that? And if it's cost effective, why wouldn't we expand that to the rest of the Medicaid population?
Here's a technical question about the eligibility. So the eligibility standard is 138% of the poverty line, which is about $15,800 for a single adult. And the person points out that in other programs, general assistance, food stamps, there's a check on bank assets, utility bills, and so on, and they're asking whether this will also be done for Medicaid.
No, actually, there is no asset requirement. So that's important. So if you have a house, that's why I was giving the example of someone who is 60, an adult, and with an engineer but can't get a job. They could have a valuable home. But if they don't have, and if they don't, and they could even have some savings, but as long as their income is zero, they're going to be eligible for Medicaid.
Here's a question for John. It's estimated that Medicaid HMOs will get $4,000 to $8,000 to cover each new Medicaid recipient. 90% of people are not sick. Why do taxpayers need to fund $5,000 per year for people who are not sick?
Fair question. So I think there are a couple of things to respond. One, 4,000 to 8,000 is quite a stretch of money and big difference. At this point, in terms of the Medicaid expansion population, we have no idea, frankly, how much will be paid. One of the operational challenges for the state in getting the program off the ground is typically the way one sets a rate is you have an actuary who looks at last year's utilization, figures out what inflation is going to be, and that sort of drives what the rate is. When somebody hasn't had coverage, there's nothing to sort of point back to and say, okay, well, how much is this going to cost? So, but to the other nature of there are healthy people and there are sick people. I think as a lot of you know, there is sort of an 80-20 rule. 20% of the people drive 80% of the cost. The challenge that the state and anybody who is a payer faces is it's not always clear who's going to be that expensive person. You don't know year to year who is going to cost you a lot of money. There are some babies that are born and we end up spending $1 million on that child. And that's right, and that's what we should do. But it takes a lot of healthy people when you're collecting $100 a head or something like that to cover $1 million expense.
Also, I just want to add that because I think that the person who was asking that question sort of raising, are we getting good value for our dollar? And Medicaid is an incredibly efficient program. And the rates are significantly below in the private sector, and a lot of it's because of the negotiations. And I know it doesn't always make the HMOs happy, and because the state has to negotiate them for the best price. But the state is being a prudent purchaser, and they're representing the taxpayers of our state. So they try to keep these costs down. Some people are criticizing because that they are actually too low. But when these rates are factored in, you look at the health of the individual. So if people are not participating in the program and they are healthy, then presumably the rates are going to be lower.
Can I just say?
Sure.
I like the definition of prudent purchaser, but I just want to say whenever someone can buy something for less than it costs, I guess you're a prudent purchaser because the Medicaid program in New Jersey does not reimburse for the cost of the care that that is provided by hospitals or doctors. So, just wanted to make that point.
Will Medicaid
Taxpayers, you should be happy.
Yes, taxpayers happy, hospitals not happy. No.
Will Medicaid expansion eliminate FQHC copays? Does anybody happen to know that?
I don't think so. No.
But can I just talk about that a little bit? Part of what I talked about a little bit earlier about accountability has to also includes FQHCs, and my experience is that there are FQHCs that do phenomenal work, and my experience is also that there are FQHCs who don't. And there are FQHCs who don't have a cooperative agreement with their local hospital. They don't have a cooperative agreement with outpatient clinics. They don't have a cooperative agreement with taking the uninsured from hospitals. While it is that, and I'm going to get in trouble for this, but while it is that FQHCs receive millions of dollars in state and federal money, grants and otherwise, almost on a regular basis. And just like hospitals and legislators and everyone else has to be accountable, they have to be as well. And I've experienced some frustration with some of them, with some hospitals and with some others, and this isn't a perfect world and it's not a perfect business. But they have to be as an equal partner and an equal team, and they have to be accountable, and the money that they receive there has to be a return on investment. There's this ungodly amount of money being given to FQHCs, and that's great. I mean, they provide care in so many ways to those who can't get it anywhere else. But there has to be accountability, there has to be partnerships, and they have to be real and connected, and they have to be accountable. So that's my comment on that. Thanks.
I guess this is a broader ACA question, but how will this help in terms of the hospital being able to see medical records of patients who attended other healthcare facilities? So a medical records question. Does anybody have a take on that?
Well, I know that hospitals are working with other hospitals in their area to share IT, and we are moving in that direction. I don't know if the ACA specifically outlines that, but it is something that hospitals are working on in collaboration with their area hospitals, because you want to be able to, by patient, identify if they've already had the MRI or they've already had the X-ray to save healthcare costs. So you don't want to do it again if 2 weeks ago they had the same test at a neighboring hospital. So my members are working with hospitals in their area to work to try to coordinate that data.
Okay.
Can I just add to that?
Okay.
In terms of integrating health information technology, actually it started with the ARA funding. And as a result of high tech, not only did providers get incentives for going electronic, both physicians as well as hospitals, in terms of meaningful use, but also in terms of bringing all these different disparate data elements together. So what we have here in the state, as a result of the Department of Health and our HIT Commission, is an initiative going on around HIEs, or building health information exchanges. And at this point, I can give an example of what's happening in northern New Jersey, where we have tens of hospitals sharing information. We have freestanding radiology facilities sharing information. We have lab data coming in. Is it perfect? No. But is it a start? And is this what's going to help remove the redundancy and the duplication in the system, and at the same time empower patients so that they can bring about change? There is nothing that brings about change in physician behavior or changing our healthcare system than consumerism. When a patient comes to me and says, this is what I need and this is what I expect, that's when I make a change. So this is going to be critical. The health information exchange movement is going to be critical in our state, and there's a lot, I mean, all the hospitals are working in that direction. There are some regions that are more mature than other regions, but I see this as a huge critical success factor if we're going to make our Medicaid program successful.
Okay, here's a question. People on Medicaid are twice as likely to go to the ER. They're asserting this, I haven't checked this, but are twice as likely to go to the ER for primary care than patients with no insurance. How will expanding Medicaid save any money? Anybody have any response to that? Thoughts on whether it's factual?
Well, I mean, the coverage will come from 100% from the federal government, and the way it will be paid for the way the managed care companies will be paid for will be from the money that the state receives from the federal government, and it will be managed that way. So just because they go to the emergency room doesn't mean they're not getting care that's necessary. You know, we would like people to go to their primary care doctor and use the clinics. And once they come to the emergency room, they are then advised to then, you know, your next appointment, your follow-up is at a clinic. So I don't want people to think that, you know, visiting the emergency room is always inappropriate. A lot of times, many of us go to the emergency room because we think, you know, we have an urgent care matter. So, you know, we just want to make sure that the next visit, the person goes to the appropriate place if we can direct it. So we try to do that.
You know, if I might. So this issue of ER use and inappropriate ER use is very difficult and multifaceted. And I think it varies depending on the region of the state that you're in. You know, one of the things that is a challenge of that is, yes, there are the frequent flyers who appear at the ER. Frequently, there you've got behavioral health problems or substance abuse problems, but one of the other challenges in terms of absolute number of visits is those folks who show up once or twice. Mm-hmm. And they show up once or twice for a condition that really doesn't require them to be in the ER. So if you think about the Medicaid program, we have about 1.1 million people in that program. And if they're only going to go to the ER inappropriately once, how is it you effectively target them in advance to try and get them to go to your PCP? And the thing that really makes that difficult, and I'm just looking at the information from the claims data for our plan, but I have no reason to believe it's different for any other plan, is the overwhelming majority of those folks who are showing up at the ER once or twice for a reason that doesn't really require it, they've gone to their PCP. They've gone to their PCP. Now, what is driving that, and trying to figure out who that member is a real challenge. Is it the mom who has brought home her child is only 8 weeks old, she's a first-time mom? I know my wife and I, we brought our kid right to the emergency room. It was, what are we going to, we're going. Did that once or twice. There's sort of a different story, and figuring out the intervention that can do that cost effectively is very difficult. And that's difficult, frankly, for all of us. You know, I don't want to get into the challenges the hospitals face on that. I can't be totally blind to the fact there are billboards, but there are plenty of members who they go to their PCP and they go to the ER anyway. And what the answer is for that is a very difficult question. I think a bunch of us have a bunch of different programs to try and solve that, but my candid thought on this is there isn't some silver bullet out there that's going to solve this problem. It's going to take a lot of different things, and frankly, it's one of those problems that's going to be with us. It's a question of, can we make some progress on it?
Can I just add something? Actually, Mike Keevy, who is the CFO of Medicaid, actually backed up what John said. I was on an ER task force 2 years ago, and we thought that the majority of they call them lane visits, low acuity, non-emergent visits to the emergency room, our assumption was that it was the frequent flyers. And it was actually patients who had visited the emergency room between 1 and 2 times, and those patients had also visited their PCP. So it's really complex, and there's not one simple answer. The reason that we had this task force was to look at the time, and this happens every couple of years, there was a proposed $25 copay to Medicaid patients who access the ER. And some people say that that's appropriate because we all have that in our insurance programs of commercial, and others say from the hospital perspective it would just be $25 less reimbursement because it will not be collected. And even others say that it could be devastating and preventing people from getting necessary care. So there was a lot of controversy around that, and we met and we had several months of debate and how do we address this. And one of the things that came out of it was maybe the statistics aren't accurate. Maybe saying, and I think it was 62% of emergency room visits by Medicaid patients were low acuity non-emergent. Maybe that's really overstated. And the reason that we came to that conclusion is there are 2 different schedules. There's the triage nurse, what they say is emergent when you come in on a scale of 1 to 5. And if you come in and you think you're having chest pains and you're having a heart attack, that triage nurse is going to say, well, that is an emergent case, and you're going to get a number on a scale that designates that as an emergent case. At the end of the stay, you might have had indigestion and you got antacids. So now on the bill, you were treated for indigestion. That is what then the state is looking at on the UB data and saying, wait a minute, this person went to the emergency room for indigestion. So my point is, what may be reported as low acuity non-emergent was really thought to be emergent when the patient entered the hospital. So one of the suggestions we had, and a lot of things tie into IT, is there a way to tie that initial triage schedule and the ending diagnosis, because the final diagnosis, because just looking at only one piece of it doesn't tell the full story. So maybe it was really an emergent, at least thought to be an emergent case when the person went to the hospital. So there are a lot of facets to this for sure.
What assistance will the state provide the medical community to determine the number of new patients that will flow into the system so that the community can plan for an increase in capacity? I guess the state or federal government or anyone, how do you plan for this increase?
I don't know if the state has contemplated that. If they are contemplating it, I haven't heard. So I don't know what it is that they'll do to prepare, all of us, prepare providers at every level for this potential influx. There's nothing yet been articulated by the administration, by the department.
I mean, I think part of the challenge, of course, is that the governor just announced this, and so they really couldn't do anything. And but I know we've had meetings with the staff, and I think that they understand the challenge before them. And I guess the question is how much information they are going to have to share. But I think it's a good point. We really need to look at this in a quantitative way and establish enrollment goals. And I think the sharing of the information is going to be very, very, very important.
Dr. Alleg.
I just have some very preliminary data in terms of how the estimates, were calculated. So the 100,000 were the non-dependent children adults. So that was, or the 104,000, whatever, that final number. For the enhanced eligibles through the enhanced FMAP matching, for which we're now going to be getting 100% of federal funding, there are 145,000 parents of the CHIP program or the family care that are going to, for whom we will be getting as a state 100% federal funding. We will also get 100% federal funding for 44,000 adults who are on our general assistance program. And we're estimating about 60,000 parents of CHIP who have not yet enrolled in family care. From the woodwork effect or the old eligibles, for which we're estimating a 50% FMAP, the calculation that the state came up with is 90,000. So that's our starting point. I know there are projections in terms of what's going to happen year over year, but unless, this is sort of the big picture. If everyone came and got either moved, we know for the enhanced eligibles, they're automatically going to get moved into that category. But in terms of the woodwork effect or the new eligibles, those are things that we're going to have to start working on.
Many of the governors who have announced that they will not expand Medicaid eligibility have cited what they're describing as uncertainty over the federal commitment to provide the 100% match for the first 3 years, ultimately falling to 90% by 2020. Governor Christie, in his budget address, said that if things were to change, if the factors that went into his decision-making were to change, then he would change his mind about the expansion. What are your thoughts about the odds that the federal government will uphold its end of the bargain and what the implications are for the state?
Yeah, well, I think that, it's interesting that statement has been made because actually the Medicaid expansion is probably the least likely federal funding program that is going to be cut. We all know that there's all kinds of federal cuts that are being done through CA question, and there's more in the future. The Medicaid is exempt from that CA question. So it's interesting that everyone's focusing on the Medicaid expansion when actually there's all these existing programs that are being cut. They should be worried about them. We all know, both in this country and the world actually, that health reform is the #1 priority of the president. And he has made it very, very clear that he is not going to gut health reform, and he specifically would oppose any reduction in the Medicaid expansion. Also, this problem is addressed by some states have put a circuit breaker, so-called, and in their legislation, which the governor said that he wants as well, which is that if federal matching falls below a certain level, the state will simply no longer expand the program anymore. And I think there's, I don't know if we need that, but this is, the state's guaranteed 100% of the funds they can get out at any time. So I see absolutely no fiscal risk to the state. Just the opposite. I think for the next few years, the only game in town in terms of Medicaid funding is going to be the Medicaid expansion, and we better jump on that train right away.
Go ahead, John.
No, I was just going to say, let's envision a scenario where a Republican is elected president and they decide that they want to cut Medicaid. I have a hard time seeing governors, Republican governors who's expanded, allowing the president to do that. Just think of the politics of that. The governor's going to get a few pennies back because they're paying 10%, and they're going to throw 100,000 people out of coverage. I think the sort of cost-benefit analysis for the governors on the short end of the stick is going to be one that's going to lead them to be quite angry.
Senator?
Yeah, I don't, I agree with everyone here. I think everyone in the room probably as well, that the governor won't cut it, and it's unlikely because the federal government will withdraw some of the funds. I mean, there are, I don't know the numbers in the teens of governors who have opted out of the program, and they're wrong. And I can't know how that is that they can reconcile those decisions when they have hundreds of thousands of their own residents without health care, and many of whom won't be eligible for an exchange, whether that exchange is a federal exchange in their state, because many of them have opted out of the state exchange or hybrid. It's all federal. So it's unbelievable that they did that to those people, and hopefully that'll change in the future. So it's unlikely that the federal government will cut back on that money. There are too many folks in Congress, too many states that are now going to be rewarded or receive all of this money, and I can't see that being cut back. So it was a political statement to say, it's sort of like, I love, this part of the Affordable Care Act, but I really don't like it, but, I'll take the money and whatever, so.
Another question.
I'm glad he did it. It was a smart decision to make.
Another question from the audience. Is there an opportunity created by Medicaid expansion to also address solving and eradicating the social determinants of health, like education, housing, job creation? Changes in healthcare alone may not drive the transformation that is required. Any thoughts?
Well, the best way to solve a bad economy is with a job, or people who have difficulty in their life, whether it's affording health care or food, is a job. But having health care means a lot to people who are chronically ill or may become so, because they don't have the preventive medicine, they don't have the wherewithal or the access to care, whether that's just primary care or specialty care. They forego care. It's not a huge percentage, but it's a lot of people. And so that, you look at the workforce and the amount of money that it costs us to treat the uninsured, what it means to businesses who don't have employees who can be reliable sometimes because they don't have access to care, and they're sicker than they should be, and they're not cared for when they are sick in a timely manner, so it affects business as well. And so it's overall, all our way around, it's, a healthy person is going to contribute to themselves, to their families, to their community, if it is that they're in good shape and have access. It doesn't mean they won't get sick. We're all going to get sick, and we're all going to, pass on someday. It's inevitable. But, to be able to provide, look, all of us have health insurance, I would suspect, in this room. And imagine going to, I'm sorry. I know why you've been clapping so much. It's great. Good. But we go to bed every night, put our head in the pillow, and just don't even think about it. We go to bed tonight and just sort of pretend you don't have health insurance. It's going to be gone in the morning. And what would you think? You'll have cars and homes and bills to pay, and then get sick and rack up hundreds of thousands of dollars in bills. Changes your perspective on life.
Also, I just wanted to add that, the great thing about Medicaid is that it is surprisingly flexible, given that it's an open-ended entitlement. When I was at the department, we were operating around 7 divisions. They were very, very diverse in terms of welfare and services to people with disabilities, child protective services, and the one common funding source that we had for all divisions was Medicaid. And so you can use it for case management, you can use it for a lot of different services in mental health. So I think that we should look at this in a holistic way, in terms of this is not simply a matter of acute care and folks going to hospitals. This is a new funding source that can transform people's lives and make them much more independent.
I think the one thing that I would be remiss if I didn't talk about is the Innovation Center that CMS has. And through that, there are lots of opportunities for demonstration and pilots, especially around workforce development and really engineering the workforce to meet the needs of what our population is. So that's going to be an important piece as we develop a stronger systemic approach to improving our healthcare delivery model.
Thank you, Doctor. Medicaid itself was created in 1965, and states had an option as to whether to opt in, and it took until 1982 for Arizona to be the last state to opt in. I think there's more than 20 states that still haven't decided whether they're going to join this. Do you see Governor Christie's decision either having influence or the thought process that he used being used by other governors as they make this decision, particularly Republican governors. I know it's a political question, but anybody who's interested in answering it, I'd be interested in your perspective.
Passed. Senator Passed. I think the answer is yes. I mean, it's clear that the governor's half hug of the president notwithstanding, he is still very popular in the Republican Party, and I think what he does matters. I don't think it's, I mean, there were governors before him that were Republican, who were actually more conservative, who had decided to do this. But sure, it has the fact, and I would imagine that our next door neighbor, Governor Corbett, is feeling the heat now, because now every state around Pennsylvania they've all decided to expand Medicaid. And imagine the inequity there now, because in Pennsylvania, if you're in the Medicaid expansion and you have to go to a hospital in Philadelphia, all right, and right next to you is the same person who has the same needs and same income, and they live in Pennsylvania, they're not going to, their care isn't going to be paid for, but the New Jersey person is going to have their care paid for. That's an enormous inequity. And then to make it even more inequitable, the taxpayers in Pennsylvania are still going to be paying their federal taxes so that we can expand Medicaid in New Jersey. So I don't know how long the taxpayers in Pennsylvania are going to stand that. So I think it's going to have some effect.
Well, as we get close to 2 o'clock, unfortunately, we're not going to be able to get to all of the great questions that we received from the audience. Do any of the panel members have any closing thoughts that they want to add? Okay, well, if not, John?
No, simply I would just remind people in terms of we can never lose sight of the fact of why this is necessary. Senator Vitale alluded to it. The income group we're talking about, they're making 15 grand a year. If you go look at New Jersey's individual health care insurance, the most popular plan is $1,000 a month. So 1 month of premium costs them 6% of their annualized income. That's almost to the hardship threshold for annual spending. This has got to be, it makes common sense. It's a good thing that it's here.
I think that with all the moving parts of this and the exchange and all the other elements of reform, I think we have to have, and I think maybe Ray's group and others could talk about benchmarks. And I think we should talk about and think about establishing benchmarks on how we should move forward, what elements of enrolling people into Medicaid. We talked about a variety of the elements and pieces of that puzzle that have to be accomplished to get people even in the program, and then paying doctors and making sure they stay in the program. Establishing benchmarks, whether annual or every few years or whatever it is, and then also having maybe some thought as to how it is that we address the benchmarks if we don't meet them. So to think about the benchmarks and or corrective measures ahead of time. So we'll establish the benchmarks, but also have Plan B and Plan C if the initial benchmarks don't work. But sort of like we're all run out of the room today, and we all have a bunch of great ideas, and we want to enroll all those folks who are eligible. It's going to take some thought. And I don't know that the state will do this, or can do this, but certainly groups like Ray's and others can. So it's something we should think about.
Thank you, Senator. Anyone else?
Well, one thing I'm so encouraged about is that a lot of the folks, and some of the folks here on this table, we don't always agree on things. And one thing I've learned in the healthcare industry, that there's a lot of disagreement even within the industry. This seems to be one area where we're all very supportive of. And frankly, I'm a lot more optimistic in terms of our ability to work together as a team. This is the only way, it's not going to be the federal government that's going to determine the success of this program. It is definitely going to be New Jerseyans. And we have to come to our own solutions, but we have to work as a team, and I think we all have a vested interest in doing this. And I really thank New Jersey Spotlight for sponsoring this, because I think this is the beginning of that effort.
Just want to say real quick, I think leaving here today, we should feel good and we should feel proud of New Jersey, because I do think a lot of us in this room, and Senator Vitale and Governor Florio, we've done a lot to put healthcare first. And I'm grateful to Governor Christie for doing the Medicaid expansion and for prioritizing healthcare funding in this budget. And I think we have our work cut out for us, but it's good work and it's noble work. So I look forward to working with the Medicaid Director, Valerie Harr, and seeing how hospitals can continue to be part of the solution.
Dr. Ale.
And again, I just want to reiterate what everyone says. The easy part was making the decision on expanding Medicaid. The work begins now, and it is through public-private partnerships that we truly are going to identify what works for our state, and we have this unique opportunity to lead it. We are at the perfect storm today.
Thank you very much to all of our panelists for their very valuable insights, and I appreciate everyone who came.
Let me quickly add, I also want to thank, give a round of applause for Andrew for his maiden voyage as one of our moderators. And we left on your, I forgot to mention, we left surveys on your tables, which we'd really love if you could fill out. They're really helpful for us in terms of planning these moving forward. But thank you all very much for coming, and hope it was a fruitful afternoon for you.
For more information, visit the website njspotlight.com. We produce these programs in the studios of Lubetkin Global Communications in Cherry Hill, New Jersey, on the web at lubetkin.net. For everyone at NJ Spotlight, this is Steve Lubetkin. Thank you for joining us, and take good care. NJ Spotlight, where issues matter.